So we're going to move on to Dr. Anita Parbhoo, who's our medical manager and acting CEO at Red Cross Children's Hospital. We're very privileged in that we actually have a great management team and we work really well together. And at a time of stress like we do have with COVID, it's really important that everybody meets and is on the same page and shares their anxieties and work together. So Anita, thank you very much for yet another Zoom webinar on a long day. And we look forward to your presentation. Thank you very much.
Hi, thank you. Thanks, Minion. I'm just going to try and share my screen and get that on there. You can let me know, is that?
Yeah, it looks good.
There we go. Great. So thanks. As Minion mentioned, I'm a medical manager at Red Cross War Memorial Children's Hospital, and just want to share with you a bit about our experience with COVID-19. So I will just start off to see where we are now as a country. And as of the stats yesterday from the WHO, we had just over 7 million confirmed cases worldwide, with over 400,000 deaths. And we are this little bubble at the bottom here, which is getting bigger. All right, just another comparison to where we are globally. Africa's this blue line, and it's right at the bottom here. So nowhere near where Europe and Americas are, but you can see us, our numbers there in the blue. Our stats as of yesterday, these are our national stats. We had 1,162 deaths with over 50,000 positive cases. And as we all know, the Western Cape is the epicenter, and our deaths are recorded there as 890.
Yeah.
And to show you where we are in the Western Cape, we have got this very nice coronavirus dashboard, which was developed by our provincial Western Cape government team. And on these stats, you can see that in the Western Cape, we've had about 34,000 positive cases and 851 deaths. This is a very nice dashboard that you can go and have a look at the coronavirus website, and you can toggle and hone into specifics that you want to have a look at. If we then move, so this is the whole of the Western Cape, and the next slide's honing in on the metro. So if we hone in on the metro, you'll see that we form about 28,000 of those cases in the metro with 851 deaths. All right, then just to look at the cases and deaths by age, I know that this is quite faint here at the bottom, but what this is there is a gray line here showing the number of cases, and the x-axis is the age groups. So in terms of the number of cases, our peak is around the 31 to 40-year-old age group, but in terms of the number of deaths, our peak is around the 51 to 60-year-old group and 61 to 70-year-old group over there. According to our national stats, we've had 5 deaths below the age of 20, and I'll chat about our deaths that we had. All right, this is just a diagram from the UK looking at the experience, and it's as of the 8th of May, and just to put into perspective where children are in terms of deaths. So the size of the bubble indicates the greater number of deaths, and you'll see the biggest bubble in the UK are deaths over 75 years of age, and then you'll see the other ages there, but they had 3 under 15 deaths. So if you try and put that into perspective with the majority of deaths, you'll see how small the patient deaths are. And it just emphasizes that we do need to protect the aged and vulnerable groups. Then just honing in on our Red Cross Hospital stats, you may recall that we had our first SARS-CoV-2 positive test in South Africa on the 5th of March. At our hospital, we started testing around the 24th of March. And this is just an overview of tests that we've done. So not positive results, it's just tests that we've done of both adults and patients. So you'll see our pediatric line there is in purple. That's the test we've done there. This is the total number of tests. And the blue line reflects per week the adult tests we've done. And you'll see when we started to take off with testing adults. Now, what falls into this adult group? The majority of this is staff, but there are caregivers in that as well. When we test a child, we test the parent as well, because it's very likely that the parent has it. So we've been testing both adults and children. And then the last week is not complete because these stats were as of the 7th of June. Then just to give a breakdown on our tests done at the hospital, majority have been in children, over 1,200 in children, and then about 500 in adults. And just looking at our tests, just to try and make sense of the stats, we have arbitrarily divided the stats into pediatric as 18 years or younger. Our hospital is mandated to see children up until the age of 13, but we see many, many more over the age of 13. And so we've used that cutoff, but you'll see majority of the tests done are in our pediatric patients. And then if we look at the age group of which patients had tests done, so again, not positive, it's just to show who are we testing. It is this under 5-year-old group, and that is in keeping with the patient population that we see. So there was no surprise there that will form the bulk of who we're testing in terms of pediatrics. In terms of positive results, so these are patients, as I said, arbitrarily results that were 18 years and younger, but there is one of Professor McCulloch's patients who's 19-year-old that we know it's confirmed it's in there. But we've got a 3% positive rate of tests done at our hospital for under 18 years and under. And then within that, you'll see that the majority of positives are again in that 5-year-old, less than 5-year-old group, which is not surprising. In terms of our staff tests done, we've had a positive rate of about 17%. And we know that there are, again, what I indicated is that there are a few caregivers in these adults, but the majority is staff. And there are staff that have been tested at private sites. I know of at least one staff member who tested positive at a private site, but at a private lab, but the majority of results have been negative outside. So we're just looking at a 17% positive rate. And then just to chat about the patient deaths that we had, because there's been a lot in the media about it, especially last week after our media launch of our tented structures. We have had 2 deaths thus far where the patient had a COVID positive result. The one patient was 1 year old and the other patient was 15-year-old. Both of those patients were chronic patients at our hospital and were being treated there for quite a while with significant underlying comorbidities. In fact, one of the patients was on a palliative care plan. So yes, they were COVID positive when they passed away, but we really don't feel that contributed to their demise. And then just how are we as a hospital managing the COVID crisis? So as per the provincial guidelines, as we are a children's hospital, we do allow a caregiver to stay at the bedside with the child. We limit that to 1, however, whereas previously we would have allowed more. And we are limiting visitors to the hospital, volunteers, etc., because we really wanted to reduce the traffic through the hospital. We significantly reduced all our elective surgery and non-urgent outpatient appointments. And we had all kinds of SOPs drawn up as to who to contact, contact patients telephonically, advise them, and then call them in only when necessary. And the plan to reduce all of this was to create additional capacity. So both to free up staff to work in other areas that were being created, like the tented structures I'll show you later, but also to create additional capacity to take on additional pediatric patients. So from the beginning, when we started to plan in March for how we as a hospital could contribute to helping to manage the COVID pandemic, we didn't expect major patient pressure in terms of pediatrics. We knew we'd get some, but we weren't expecting the kind of pressure that the adult facilities would have. But we did expect our staffing to be affected, and that has happened. And also we thought that if we could assist our other fellow hospitals, facilities around us, what would be best for us is to be able to take pediatric patients away from them so that they could focus on adults. And we have already, 2 weeks ago, transferred the Groote pediatric service across to us. And this is something that we've been planning for a while, but we had to activate that quite quickly 2 weeks ago as Groote was becoming more and more full with adult patients. And we're also in discussion with some of the other hospitals. So just trying to assist our big sisters and big brothers hospitals. Then just on the actual hospital premises, we were fortunate enough to have these tented structures created, and we've got 4 of them on the premises. This one in particular, tent 3, is for coronavirus testing. And we as a hospital are still only, we're a tertiary facility, and we're still only wanting to see patients that would normally come to Red Cross Hospital. The purpose of these tents were just to create additional space to physically separate patients. So we wanted to separate the patients that were coming with non-COVID related issues from those that were coming with possible COVID symptoms. So we want the suspected COVID patients to come into this area. They get screened here, they get examined, and at the back there are 2 negative pressure ventilation rooms where testing can be done. And then they can be handled accordingly. So if they need to be admitted, they would go straight into the COVID ward in the hospital. If they needed to be discharged, they would go on to another area where they'd be fully examined, medication given, and then discharged. We're very lucky. Oh, somebody needs to be muted. We're very lucky to be able to have these beautiful child-friendly panels designed by our Children's Hospital Trust and donated by GL Events, who's one of the contractors that were working on the tents. That was just at the media launch last week with the Premier and the MEC present. And it's lovely to be able to have this child-friendly place where children can come, because it is very anxiety-provoking. That's just outside the tent screening that was happening on the day of the launch. And then we've also had to establish other areas. So Professor Zulka, who's a pediatric cardiologist, had got involved quite early on at Groote Schuur Hospital in assisting with the adult testing site. And we and the clinical team decided that we had to institute a staff testing area for our own staff at the hospital. So we had to set that up and stock that appropriately, and we are just doing testing in the mornings, and staff are kept socially distant, and they are screened and then tested if necessary. We also had to start doing daily screening on entering the hospital, and we have these lovely scanners which were donated by Children's Hospital Trust, and we have many of our staff who are aspiring 007 agents. So it's all been a bit of fun and also a morale booster for staff to be able to do this. I just wanted to chat to you about just managing staff during the COVID crisis. And it's been really interesting trying to understand where people are at. So we all react differently to periods of anxiety, and we go through different stages. And this is a useful tool to just look at where are people, you know, in terms of, are they in the comfort zone? Are they still quite fearful? Have they moved out of the fear zone towards learning? And are they in growth? Because you'll find, what we found is that staff have such high anxiety levels, and we have to try and deal with it and try and make people feel secure. And we've had to be very adaptable. We've changed the way we all are doing the digital platforms for meetings, which quite frankly, it works a lot. You miss the social interaction, but they do work well. We've had to flex into different roles and departments, and we've had staff that are really, really amazing and showing wonderful teamwork, and really it does speak to the organizational culture at the hospital and the province, and support from our academic heads of department. And that's been great, that we've been able to work as one united team and thrash things out, make decisions, and implement them. But to be honest, this is how we feel most days. But we carry on. We've had lots of innovation, developing different products and collaborating with different groups. And we've also had a whole lot of energy put on the cloth mask project, where we've got communities, etc., to sew these cloth masks that Professor Zar was talking about. And there was also the MEC had launched the Ubuntu Cloth Mask Initiative in the Western Cape to try and provide communities with cloth masks and also provide some income for people that are not working. Then just in terms of information, one of the things we were asked by our staff is people want information. They want to know what's going on. And so we send out information to our staff every day during the week, and we send out our hospital statistics. We send this out on our WhatsApp groups as well as via email. so that staff can share it. It helps people to know what's going on and to hear it directly from the source. So we try and share that information. So this is actually today's message that went out. We've had 88 staff in total with COVID, but so excited to see 65 back at work, and that's been amazing. We actually had a hand clapping ceremony, I think on Monday at 10 o'clock in the wards, just to welcome those staff back. So far, we've had 55 patients in total. This is a rolling total, so right from the beginning, and not even, not all those patients were even admitted. Today, we had 9 patients positive in the ward. The other information we send out every day is sending out a key message, and I borrowed this idea from Great Ormond Street in London, where they felt that they needed to send out a key message each day to the staff and also for supervisors, so supervisors could remember to share this message with their staff. So today our key messages were about our staff returning to work, 65, and also just reminding people to get their influenza vaccine. We also provide our provincial hotline number. We've got an after hours COVID query hotline number that is manned by our occupational health team, so that if someone gets a positive result and they're not sure who needs to come into work, who they're exposed to, they can get that information after hours. And then also our employee assistance program number, that's our provincial program, if people need advice or support or counseling. Then, as we've seen in all facilities, we've had the saga of tea rooms and travel buddies. So it's been quite an exercise in getting physical distancing. And it's almost easy in the clinical areas because people have a certain level of anxiety. They wear the correct PPE generally. They keep socially distant. They do what they need to do. But then they move on to the tea rooms. They take the mask off to drink the tea. They forget that the mask's off. Someone comes across to show somebody a photo of their child on their phone, and it all falls to pieces. So that's been a constant battle. But I hear that that's a challenge all over, just trying to deal with that. We've tried to use a 3-pronged strategy to address that. So through awareness, reminders, the notices, our key messages that we send out every day, as well as having team discussions, and then physical enablers. So actually making marks or crosses on the ground, taking out chairs. So we've gone into tea rooms, measured it, worked out how many staff can be in that tea room, and then put a notice on the door, but also take out some chairs and leaving only the number of chairs that should be there. We also, in terms of nursing tea times, traditionally nurses have 2 tea time shifts, and we've had to split that into 3 just so that there are less people having tea at a certain time. And then just in terms of enforcement, just to kind of be visible, managers going around the areas to chat to staff, but also to remind them of the social distancing. This is just some examples of the social distancing. So this is in the center there. It's a tea room of my occupational therapy department. It's not normally their tea room. They're just using the space because their tea room is too small, and you'll see there very few chairs and they're very far apart. On the left is our foyer of our outpatients, and they're physically marked on the ground where patients should stand when they come in there. And then on the right, this is also the entrance leading up to the outpatients area where we've done markings on the ground. All right, so it has been an ongoing journey for us. We've tried to use an collaborative management approach, trying to build trust and foster teamwork, and try to listen to staff as best we can. And just acknowledging this concept of knowledge power. So not trying to hold all the knowledge at the top, but trying to share it across levels of staff. And that's partly the reason why we're sending out those daily stats. Understanding and explaining to people that we're on a learning curve, and just because we did something 2 weeks ago in a particular way doesn't mean we're doing it now if new information's come to light. And an important thing is to take labour representatives along on our journey with us. So we have labour reps represented at our meetings, in my morning situational report meeting every morning, and also having one-on-one sessions with them to hear what their concerns are and try to figure out a way forward. And just providing emotional and psychological support to staff. As I mentioned, there's high anxiety levels, and we do this through a combination of ways, in-house wellness teams, our psychiatry department, psychology department providing support, our occupational health and safety department, and also our provincial employee wellness program. So that's really been important to try and do that, and also boost staff morale. So we do try and celebrate the little wins and celebrate birthdays and retirements when we can. But we've really been blown away by gratitude and just seeing the immense kindness shown by people, communities, some NGOs, for us, our Children's Hospital Trust and Hospital Facility Board, companies, communities, and for both patients and for staff to boost staff morale. So we had food parcels, we've had pizzas, we've had biscuits, and we've had toiletry packs for patients, etc. And it's all helped to boost staff morale, because for staff who are in a position where patients and families need help and they're unable to provide it, it's very difficult. So it's great to be able to discharge a patient who needs to take medication. You're able to give them a food parcel to go home so that you know they're not having the medication on an empty stomach. So just to end off with just some websites there, and where you can get some information, and also our dashboard, and that's just our Children's Hospital Trust website, and there's some other information that you can use. Okay, so let me just stop sharing there.
Thank you very much, Anita. Aren't we lucky to have such a compassionate boss who can share her thoughts and ideas with us? Thank you very much for that presentation. I'm going to let you catch your breath. And the one thing I think I've learned through all of this is that everything changes almost on a day-by-day basis. So just because the rules are such in the morning, maybe in the afternoon we've changed. And I see a lot of you have commented on Heather's discussion where she said WHO made some statements, and they did change or retract some of those statements pretty quickly. And I think in this game, we're learning as we go along, and it is about being open and flexible. So Heather, I'm going to put you on the spot and say I am a pediatrician and I need to advise about the use of masks on younger children, specifically nursery age, but also ask, can we rather use visors? And that's a really topical question. So what do you think about that?
Yeah, thank you. Thanks. And this is an important question, especially as children go back to school. And there are a lot of questions about, must children wear masks? Must staff wear masks? You know, could visors do it? So I think masks are better than visors. Visors are just really a barrier for, they were actually developed, you know, as a barrier for surgical splashes and direct contact with infectious particles. They were not developed for containing aerosolized spread. So actually the recommendations for visor are that a visor should always be used in addition to other personal protective equipment, particularly a mask. In terms of children going back to school, it really is important that children wear a mask and that all staff wear masks, because as I showed you, you know, masks are highly effective for preventing transmission. There are children who it's difficult to wear a mask in, like young preschool children, and you know, they're not recommended for such young children. And there may be, you know, visors may be useful. But generally, in older children, visors on their own, when in adults, visors on their own aren't recommended. It's much safer to use a mask.
Great. And then just an extension on that, if we're needing to preserve N95, is it feasible or suggestible to use a surgical mask together with a face shield as an alternative?
Yeah, so I mean, again, this is all information that is coming, right? And we don't have all the answers. Generally, what that WHO Lancet paper showed is that you get protection with additional protection. So if you use a mask, surgical mask, and you then use eye goggles or eye shields or a shield that covers your face, eye protection, there's an additive benefit. They didn't specifically evaluate masks plus visors, but they looked at eye protection and masks. So there is an added benefit with eye protection and added to masks, even for N95 masks. Because remember, even though N95 masks are really great in terms of being highly protective, they're not completely protective. So the addition of eye protection would be good. Also, just to, to remember that we can't really get N95s now. We're getting KN95s, which are the Chinese version of N95s. Some people say the seal on them is not as good as the N95 mask. So, there may be lesser protection from the KN95s that we have. And it seems wise to protect our healthcare workers where there is a lot of exposure, where our emergency rooms are seeing increasing numbers of cases of adults coming in with respiratory disease, with COVID, the ICUs and so on. It seems wise to protect our healthcare workers with the best protection that we can offer them, and that would be an N95 or KN95 plus eye protection.
Great. And then, as you know, SAPA last week did quite a lot of work in putting together a document suggesting that it's a good idea for kids to go back to school in a staggered approach, year 7, year 12, social distancing, make sure there's good hand hygiene, make sure everybody wears a mask, as you said, both the teachers and the kids. We're not saying no child will get infected, but we know that children are less likely to get infected than the adults. But somebody just posted a question. So many nursery schools are insisting or suggesting only visors for young kids. I don't know that we, from a SAPA point of view, have the answer for that. We've been asking ourselves that question. Is it safe to allow? What's your feelings on the younger kids?
So, I think in nursery schools, masks are impossible. Young kids can't wear masks. And visors are second best. Having said that, I think we have to keep this in context. And, you've had a webinar where Shabir and others spoke. And just to reiterate, children are at very low risk for infection, for disease, and certainly for severe disease. You saw Anita showed the statistics of number of children who've died in the UK. In Italy, there's not a single child who's died. In the whole of Wuhan, there was one child. We're very fortunate in this epidemic that it is really affects children very mildly. Either they develop asymptomatic illness or they become mildly symptomatic. So, for me, the worry is not so much about infection in children. The worry is about infection in adults. And so what I would think would be most important in nursery school settings is actually for the teachers and the staff to be well protected, because if the children are going to get infected, it's also most likely to come from an adult member. So, also that age group of 1 to 5 years is of all the childhood age groups, that is the lowest risk age group for infection. If we look at the the data from other countries, the highest risk age groups are in the adolescent group or in the under 1 year age group, all of whom still develop very mild illness. But that preschool age group is really, really low risk for getting infected and for getting severe disease. But the teachers and the staff are at risk for transmitting and for getting infected from each other. Adults to adults, adults to children is the predominant route of transmission, not child to adult.
Thank you. And so we've had some discussion from a SAPA point of view that people are very anxious to send their kids back to school, but feel that it's a good treat to take them to the shopping mall with them. And so it's about just thinking very clearly about that kind of thing and the anxiety that we try and reduce.
Adults are much more likely to get infected in a shopping mall, even in their workplaces, than they are from their child going to a nursery school.
And I think we've been very upfront with a number of adults, both parents and staff members, who've actually acquired this in our own hospital. And I must say, in our experience, even on our ward, it was tea rooms and traveling buddies. And I think that's really hard. Some of the taxis are really resistant to social distancing. I hear one group of taxis are giving masks out and then taking them back at the end of the ride to give to the next patron, which is obviously not ideal by any means. But I think the tea rooms, people are nervous, people are anxious, and the best thing to do is to huddle or cuddle with a buddy and look at your cell phone pictures or whatever you want to do. And I think it's a real culture change to say this is not the time to be sharing a cup of coffee with your friends or your colleagues. So I think that's really, really important.
I think we could also push going outside. I mean, we're not today in Cape Town, but I think it's beautiful weather in Johannesburg for those of you there. But we need to encourage our staff to go outside to get some ultraviolet light, vitamin D, which may also be protective, and just to take some time out outside. And maybe that's something we should be doing in our facilities, putting a bench or, added opportunities for staff to enjoy the outdoors in their tea break or lunch break.
So we've definitely seen an increase in violence amongst children with the recent reduction of the alcohol ban. And I think that's a big thing, is in some areas children may not have food security, they may not be safe at home, and so the safest place for them may actually be to go to school. Obviously that doesn't count for everybody, but that is something that we feel as SAPA is really important. But also important to teach the whole community to wear your masks, to hand sanitize, and some social distancing. Anita, a question for you. Did you move all the neonatal units across to Red Cross? And how do we accommodate all the pediatric children coming from all the hospitals in the area?
Yeah. So no, we didn't move the neonatal service. We were just, the plan was last year to move the pediatric service across. So Groote Schuur, besides the neonatal service, which is linked to the obstetric service, still had 20 pediatric beds. So 10 of those were general peds beds, 6 were endocrine beds, and 4 are neurosurgery rehabilitation beds. So the endocrine service, Groote Schuur and our hospital work very closely together. Our clinicians work between there and also other hospitals. So our endocrine service, we actually have the outpatient service based at Red Cross Hospital, but it was just the inpatient service that was left. So we've moved those beds across, the rehab beds, and then the 10 general pediatric beds have come across, and that will stay. But in addition, during this COVID time, we've also taken across the adolescent service where it needs to come across, but that's a temporary thing until we go back. Just in terms of the bed numbers, remember I said we had decreased, we've stopped all purely elective surgery, remembering that in children, there's a much higher percentage of urgent and emergency surgery than in adults. So, but there was some reduction in purely elective surgery, and then also outpatients, etc. So we still have some bed capacity. And as a children's hospital, the thing that we find the most is still always pressure on our high care beds and ICU beds. So, we're managing, and we're still in a far better position than our adult, colleagues, our adult hospitals, Groote Schuur and Tygerberg Hospital, that are really overflowing with adult COVID patients. So we manage it, and it's a flexible thing. So if we manage what we can on a day-to-day basis, and it's always like, just put another patient in here and make a space there. And we tend to do that in our hospital.
Thank you, Anita. Heather, a question for you again. Reinfection. What is the feeling on reinfection? And I know you're doing some interesting work.
Yeah, so that's an important question. Thank you. And I don't think we know the answer. There are a number of studies going on looking at antibodies, at healthcare workers who develop antibodies, how long they last for, and whether they're protective against future infection. What's interesting is one of the reasons why children are thought to get such mild illness is because they more recently experience a different coronavirus. So we know there are at least 4 circulating coronaviruses, not COVID, they don't cause COVID, but they're called endemic coronaviruses that generally cause very mild illness in children. They usually cause like a cold. And we know that children get those quite a lot. For example, in our birth cohort study, we know that about 20% of children get those viruses in the first year or 2 of life. And one of the predominant theories at the moment is that antibodies to those endemic coronaviruses are protecting children against SARS-CoV-2, against getting COVID. And if that's true, then one would hope that if you do have an infection, then the antibody protection is lasting and will protect you for repeat infections. We haven't seen big second waves in people who've been infected initially. The second waves that are coming out in Southeast Asia are where there are new cases and people who haven't been infected are being infected. So there's not a strong suggestion that if you're infected, you lose your immunity. And I think you know, we'll have to wait and see what studies show. But if you ask me what I think it's highly likely that once you've had the infection, you do have some long-term protection. And probably you have cross-protection if you've had recent other coronaviruses, as we suspect is happening in children.
Thank you for that, Heather. Question back to Anita. So we know that in a lot of adult hospitals or potentially private hospitals, parents or carers are not allowed at the bedside. So what made you feel comfortable doing it at Red Cross?
Yeah, so I think it's just a way of life really at Red Cross Hospital. That's always our challenge with doing everything, is we're not just treating the patients, we're treating patients, families, grannies, aunts, uncles, etc. And Prof. McCulloch will say that often when she has to have a consultation with the family about a diagnosis or something, sometimes it lands up being 40 people in a room. So clearly we can't do that during COVID time, but we try to manage as best we can. And that's why we have had to limit it to one caregiver at the bedside. And we've even gone as far as to say if the patient's tested positive and we've tested the mom's there and needs to be there, then we will keep them in that same cubicle and manage them together until such time that the mom can go, or we make alternate arrangements. So I think it's just part of what we're used to doing. We're used to managing parents and children, or caregivers I should say, because a lot are not parents, a lot are caregivers. And so we have to just try and manage as best we can. It does make everything a lot more challenging, however, because if the parents are staying there, then it's also about where are they going to go to leave the cubicle, to go and shower, to go, you know, and get things done. So it does make it challenging, but I think it's part of, I don't think we do it any other way at Red Cross Hospital. Yeah.
Thank you very much. And I think obviously not everybody has cubicles. We're very aware of that, and not everybody has children's standalone hospitals. But I think as SAPA and many pediatricians and GPs across the country, we've realized the importance of having a parent or a caregiver at the bedside. And so it is about childhood advocacy, which flies in the face of what everybody is doing for adults. I'm interested in that this new Hospital of Hope in Cape Town at the CTICC has got iPads apparently at every bedside, or tablets, so that people can stay in touch with their families. And I think that's been really, really hard with this condition, is that you can't be with your relative who's really ill, be that an adult or a child. Heather, I'm going to combine a couple of questions and just ask you, children with comorbidities, and that includes asthma, immunosuppression, all kinds of illnesses. From a SAPA point of view, we've said we can't cover all of that individually. We're going to say to you, contact your pediatrician, your GP, your clinic, but what is your advice on that?
So again, I mean, for me, this is a remarkable thing about the epidemic in children, that if you look around the world at children who've been hospitalized or children who've developed severe disease, it's very small numbers. And we're not seeing children with diabetes, children with asthma, children with cystic fibrosis, children with underlying heart disease being admitted in any large numbers anywhere in the world. So for whatever reason, it may be prior coronavirus infection, it may be the lack of receptors for the virus, whatever the reason, children are not getting severe disease, even children with comorbidities. And so, you know, generally the guidance around the globe has been for children to return to school. It's a risk-benefit decision, but generally the benefit of education, of learning, of being with peers, of allowing parents to go back to work, of food feeding schemes, all those benefits by far outweigh the risk of getting severe illness, even in children with underlying comorbidities. And for those with underlying comorbidities, like asthma or diabetes, I think the evidence is very good that if you're well controlled, there's really, there doesn't seem to be an increased risk compared to children who don't have underlying comorbidities. If, you know, I would say for children who are on who are very poorly controlled asthmatics, poorly controlled diabetics, children who are poorly controlled on immunosuppressives, those are children who maybe one should be more careful with. But for the vast majority of children, I think the benefits of going to school against the risks of getting COVID are completely tipped.
And the next question comes from Haroon Saluji, who chaired the last webinar.
I know, how can Haroon ask a question?
Yes, so I think it can go to either Anita or Heather. And so we saying children should be going to school, but how do we deal with school closures? How many infected teachers or children do you need before you close the school? And in my reading, I've done a lot of reading on this topic recently. Do you close the whole school, or do you just close a classroom? So I'm not sure if any of us know the answer to that, but what were people thinking about that?
Yeah, so maybe I can just start and then Heather can add. So I think if we kind of extrapolate to what we've done in our hospital, because it's a similar thing as to some people saying they've got to close a whole hospital down, and we've actually had a huge number of staff off in our hospital. So how we've approached it is, you know, coronavirus in terms of cleaning is simpler to clean than, for instance, CRE or one of those other bugs. And so just proper cleaning, soap and water is efficient. And so I suppose it just all depends. It depends on the context. So if you've got one person off in every class, it's different to having one whole class having a contact in a whole cohort. So it would depend on how you can contain, how you can limit the further exposure, and how you can clean the area. And that might mean you decide, okay, that class is not coming, let's sort it out, let's get the area clean and let them come back, as opposed to, do we close the whole school? Because I think it's going to be with us for a while. And I think, you know, some of us are privileged, and we send our children to school where they're used to online learning, where they've got access to Wi-Fi, and it isn't that much of a problem to learn from home, and where the food is not a problem. But there are many, many children, as you mentioned, out there who don't have that privilege. And so keeping them at home unnecessarily is going to cause more harm to them. And also they might not get a meal that they would otherwise get at school. So I think for us, what we found is the context is really, really important. And, you know, you would need to take that into consideration when you're making a decision about closing a school.
Heather, did you want to add anything to that?
No, I completely agree with that. I think, you know, it does depend who the contact is. If it's a single teacher, for example, and again, it's much more likely that an adult spreads to children, you know, then you might close down the class that the teacher had contact with. It depends on the number of cases and where they are. I think, you know, one doesn't want to be opening and closing schools, but of course this may very well be a reality as our epidemic ramps up. And I think Anita's point about sourcing where the infection is coming from and containing it, I think it's, you know, symptomatic, right? So in fact, you know, and we're not testing mildly symptomatic people either. So actually the risk of, and I think Shabir made this on your webinar, Haroon, was that the risk of getting other infections, respiratory syncytial virus, influenza in school-going children is much higher than the risk of COVID. And that's just a reminder to, you know, that for anyone sending their children to school, if you can vaccinate them against flu, that's a really important thing to do before sending them to school, because at least that way they're protected from one of the major infections. And we see that even at Red Cross. If we look at Anita showed you the number of children admitted with COVID. Well, the number admitted with RSV is 3-4 times that, even though our RSV season is much lower this year than it's been in prior years because of masking and social distancing and so on.
So thank you very much, ladies. So the other question is, what do we do within schools itself? And I want to thank Visor for sending me some articles early this morning, ironically by the WHO, but also by UNICEF, just looking at what schools can do and how can they think differently and smartly. So for example, do you start different classes at different times so that you don't have a horde of pupils all arriving at the same time? If you're giving meals, do you split the meal times? Do you split your break times? Kids love playing out in the playground. Do you have one class that sticks solely to itself? You don't mix classes. You don't move from one class to the next. That's obviously And then also get the community involved in, for example, if you feel that you need to clean a classroom, or in the morning, make sure you clean your work surfaces, use alcohol or simple soap and water, get the surfaces wiped down in the morning and again at the end of the day. So actually getting whole teams of people involved with that. And so it makes for really interesting reading, looking at safety concerns. And I think education of staff is really, really important, because people are very nervous about this, and it's not the school that's the problem, it's the people within the school that's the problem. So sure, you can clean your worktops and work surfaces, but it's actually people that transmit this virus. I'm just wondering what else we've still got a little bit of time for. So severe disabilities with kids who are drooling, can they be a risk to staff? Heather, I don't know if you want to just chat about that. You've kind of covered it already in terms of the small children.
Yeah, I mean, obviously there are individual children where you're not able to contain their secretions, and where there may be a higher. Or if staff are wearing masks, if they wear gloves in those sort of situations, I mean, generally the benefits for the children of being at school are so important. I don't know of any information that has showed that children with disabilities transmit more or get more severe illness. It hasn't, as far as I know, there isn't any reports of that. And there's, I can't imagine any reason why they would be more susceptible to getting infected or to more severe disease.
Thank you. And I think
there are sorry, if I can just mention, there's see-through masks for children who lip read, who are hard of hearing, and so you can get these clear masks, which are wonderful. Actually, Mignon, you actually told me about them, and that are really can be used by children who need to lip read. I mean, I think the WHO guidelines on return to school are really good. They are very practical. They're very, they're the basic guidance on environmental cleaning, on hand hygiene, on masking. And I think I think Mignon's point about teachers and staff is a key point. I think sort of, any symptomatic staff member shouldn't come to work, and any high risk teacher may, should probably not be in that situation.
And I think, Heather, you hit the nail on the head. I think things are changing all the time. I don't think any of us are arrogant enough to say we know all the answers all the time. We constantly reading, looking at articles coming from elsewhere. We're busy trying to learn. I think the important thing for me is that everybody needs to play by the rules. So if a child has got a fever, if a parent has got a fever, if a school teacher's got a fever, a sore throat, any of the signs of COVID, then you really need to not go to school and you need to stay at home. It's the same as going to work. So we're all pretty tough. We all try and not take much sick leave, but this is the one time, if you're not feeling well, this is not the time to be a martyr and to actually go to work, go to school, or go to any employment. So I think it's really important to play the game and to be fair to everybody else. I see there's a lot of stuff coming up about hypoxia, hypercapnia, and the safety of masks. Heather, I'm going to have to ask you to do that one.
Yeah, I mean, masks, remember, masks have been used in Southeast Asia for months now. There's been universal masking in all these countries, as I showed you, and very, very strict adherence to mask wearing in these communities. And I think they're safe. There haven't been reports of major safety issues. I see there's a question about should parents with comorbidities, oh, sorry, that's not exactly related to masks, but maybe I'll just take it anyway, consider not sending their children to school. I guess the question is about, is there a risk that those children then bring back infection into a home where there's a susceptible parent? And again, I would just highlight that children children generally, another reason that we think they get mild disease or they don't get any symptoms is related to how much virus they have, their viral load. And it's highly likely that children have low viral loads, and that people who are symptomatic, as in adults with illness, have very much higher viral loads. And transmission is related to viral load. So it's likely that children who are infected don't really have a low risk of transmitting to vulnerable people at home. And again, I would just say that, you know, when they come home, the first thing is the child to just wash their hands, take off their mask, the regular hygiene practices that are recommended. But what is very reassuring is, for example, there's information from Australian schools where there were 18 schools or 15 schools and a number of people who got infected in the schools. And in fact, there was no transmission. I think there was maybe one case, but there was no transmission from children who were infected to other children or within their households. It was a study of like about 850 children covering, I think, 5 primary schools, 10 high schools. So what we know is that children are much less likely to transmit the virus. And probably for someone with comorbidity at home, they've got a much higher chance of getting the virus in the shops, at work, the other places.
And then just as the last question on this topic, Heather, is there anyone who should not go to school?
Yes, so I think, some of this has been alluded to. Those children who have severe immunosuppression, who are very poorly controlled asthmatics, who are perhaps on oral steroids, very poorly controlled diabetics. I think that it's better to err on the side of caution. You know, if one could impose a lockdown, create a bubble of safety, that's obviously the safest thing to do, but we can't do that in the society, and it's not good for children to do that in the society. So if you had to ask me, who do we need to protect in this epidemic from severe disease? It's elderly people, and it's people with severe underlying comorbidities, and perhaps children with, you know, uncontrolled severe disease fall into the same, into the category of adults with severe comorbidities, but there are very, very few. So even if you take an illness like cystic fibrosis, for example, which is, as you know, affects the lungs and really impairs children's ability to breathe and lung function, in the whole of Toronto, sick kids, there's not a single child with cystic fibrosis who's got COVID. There are no reports of these children being admitted, of severe asthmatic children being admitted, you know, throughout the world. And in fact, the children with COVID don't even wheeze. They don't get that kind of illness. So I think mostly in this case, for once, we are really lucky in terms of children not getting a bad disease. And even with underlying comorbidities, they're almost 95% of children are going to be fine going back to school. There may be a few who are really uncontrolled and really severe, who one wants to keep at home.
And I'm going to extend that to my transplant hat that I also wear from time to time. And across the world, there are virtually no stable transplant children that have been admitted with this condition. So I think we can't say it's absolutely 100% safe to send your child back to school. If you're worried, you need to ask your healthcare provider. But what we do know is that children need education. We can't just wipe out this year of education for them, and this virus could be around a lot longer. Psychologically, it's safety and a food nutrition point of view or food security point of view. This is really, really a very important thing for us. So I'm going to ask Anita and Heather to give us one final last statement before we wrap up. So Anita, any final comments from you?
Yeah, just picking up on something that Alan Davidson's put on the chat, and we also need to balance that side of the thing. So, you know, everyone's speaking about not sending children back to school, but as I mentioned, with certain communities, it's important that they do go back to school, and that we just try and, in all of this, try and keep some focus and some common sense, and just try and think through why we're doing things. Because I think it's easy with panic and anxiety to kind of have knee-jerk reactions and just decide on following a certain path. And actually, if you just stop and think, and maybe discuss with one or two people and think about what's the best way forward, it's often better to do that.
Thank you, Anita. And Heather, from your side?
Yes, I would just say that for the vast majority of children, it's really beneficial to go back to school, and do it in the safest way possible. There's just a question now, should children get the flu vaccine? I think that's a wise thing to do. It will protect them against getting influenza, which there were 35,000 cases of influenza last year in South Africa, much more much more cases in children than we're going to see from COVID. So protect your children against influenza, make sure that they eat well, they get enough sleep, and going back to school is psychologically and educationally, I think, the best thing for our children now.
Thank you. And so I'm going to say thank you to the
with their masks, though. Sorry.
I'm going to say thank you to the SAPA executive, because it's been really hard work putting these webinars together, and specifically to Vera Rousseau, but to the whole group for sharing knowledge, sharing articles, sharing information. We've really tried very hard to get knowledge and information out there. And I also really want to thank everybody who's dialed into this. Share it on our Facebook, share it on our Twitter accounts, because I think anxiety is a huge factor with COVID. And everybody on this call has an interest in getting children into a better space by getting more knowledge. And so we say striving for thriving kids, even in this COVID epidemic time. So thank you very much, everybody, for dialing in. And I'm going to say, watch this space. I suspect we'll be back for more. Have a lovely evening, and thank you, everybody, for your time.